Good morning, everybody. I'm sorry that I can't be with you this morning, as something has come up. Um, but I hope that in the next 25 minutes or so, I can um, tell you a little bit about the skin cancer, uh, and that will be helpful for your rotations in medical school, and also for your clinical practice afterwards. Um, let's get started. So this is what I'm going to cover. That will include the types of pre-malignant and malignant skin lesions, what to look out for, and what other treatment options typically available in the community, and then when and why to refer to the secondary care for assessment. But before we start with the main talk, the most important thing is UV protection, as that's the number one risk factor and adjustable risk factor for skin cancers. And do ask the patients to self-monitor their skin with photos regularly, as any changes or we say evolutions are key signs of something is changing and something needs to be assessed. And proactively treat any malignant conditions such as actinic keratosis, as that's the important steps of preventing skin cancers in the first place. And if there are any signs of dangers, any signs of abnormalities, do refer early so that the patients can get the best care possible. Right, okay, so let's talk about the risk factors of skin cancer then. And as I mentioned, UV exposure is absolutely the most important factor for skin cancers. And the important quote, and it's definitely true, is there's no such a thing as a healthy tan, as tanning is it's a sign of the UV exposure to the skin, and we should take care of our skins to avoid UV damage at all costs. So UV light comes in different wavelengths. UVA, UVB, and UVC. So UVA has the longest wavelength, UVC the shortest wavelength, and therefore per photon, the UVC carries higher energy per photon than UVA. But luckily, we do have something called ozone layer in the atmosphere that blocks out more than 99% of the UVC, and therefore the majority of the UV light reach to the ground are UVA and UVB. And as you see, the UV photons with the high energy can cause the damage to the DNA, and this C to T change in the DNA is a classical signature for the UV damage. And of course, apart from the environment factors of the UV exposure, we do need to think about the host factors as well, which will be the patient's skin types. And so the lighter the skin types, you have less of the eumelanin to protect your skin, and therefore it's more likely to develop skin cancer. And there are other reasons that the risk factors can increase as well. For example, the artificial ways of the UV light. For example, patients with sunbaths or light therapy, there's a risk of increasing skin cancer in that way. There are other reasons for the risk factors as well. So, for example, the immunosuppressants that can be congenital immunosuppressants or acquired. For example, patients transplantations with renal transplant or heart transplants, they are on high doses of immunosuppressive treatment, which means that the immune systems lost the ability to screen out those early damages to the DNA and remove the damaged cells, and therefore the mutations accumulate and becomes cancers in the first place. Chronic inflammations or ulcers, that means that the local tissues will have high oxidative stress, and that will cause the DNA damage, and accumulation of that can lead to cancer. There are other genetics factors to this. For example, the PATCH gene is found in more than 90% of the basal cell carcinoma, And xeroderma pigmentosum is the patients that lost the ability to repair their DNAs when there's a tiny bit of the mutations, and therefore the mutations accumulate again, cancers ensues. And there are more and more of the genes, particularly in the checkpoints of the gene of the cell turnovers that increase the patient's risk of melanoma, particularly, which is listed here. Now, this is a section to show you about the skin. So here at the top. Here at the top is the epidermis, so it's the outermost layer of the skin, and then you have the dermis, and then the wavy line here is the basal layer, followed by the structures and the subcuticular structures. And so now let's focus on the basal layer. So the basal layers are lined by the basal cells. So that's the cells that can give rise to basal cell carcinoma. For every 10 basal cells or so, you can have a melanocyte that produces and distributes the melanin, and of course melanomas can come from melanocytes, and then the basal cells will gradually differentiate, becomes squamous cells to cover the top layers of the skin, and of course and if it turns to become skin cancer, the squamous cells will become squamous carcinoma. So yes, so this is just an overview. So what we covered will be basal cell, squamous cell, and melanoma. There will be other rarer type of skin cancer which will be beyond the scope of this talk today. Okay, so let's start with basal cell carcinoma. So let's start with basal cell carcinoma. Basal cell carcinoma is the most common type of skin cancer, full stop. And the most classical clinical sign is the shiny pearly sheen with central ulcerations and arborizing telangiectasia, or tree-like blood vessels. And this tree-like blood vessels is the most specific sign for nodular basal cell carcinoma. And the reason for that to come up is because the high turnover of the basal cells of this basal cell carcinoma means that the tumor will want to draw in the blood supply to supply to the high turnover, and that's why the blood vessels comes. And when the demand is outstrips the blood vessel supply, the centers can become dimpled, and then eventually loss of tissues called ulcerations. And the typical story is that a patient with excess skin exposure to the UV light can develop a persistent ulcer that never heals, what we call the rodent ulcer. Then that this is a sign of like a potential to basal cell carcinoma and should be checked. Then how about different treatment options? Okay, so for simple areas, excision will be the treatment of choice. When it's like closer to sensitive structures such as the eye, then most micrographic surgery should be considered, which is a special type of surgery that go through layer by layer to take out the minimal margins of the normal skin, but still to achieve a good clearance of the skin cancer itself. Radiotherapy is a good choice for certain areas and for patients that may not be benefited from the surgery. If the curative surgeries or radiotherapies were not possible, there are other destructive surgeries such as curettage can be considered for kind of palliative purpose as well. Now, It does have like some other mimics that we should consider for this very common type of skin cancer. So the first one is sebaceous hyperplasia, which is just the overgrowth of the sebaceous glands, and it does not typically has the tree branches of telangiectasia, but it can have like it's common to have telangiectasia, and that can be confused with basal cell carcinoma. And sebaceous hyperplasia can also be multiple, which is very rare for basal cell carcinoma. Syringoma is a type of appendageal benign tumors that is typically around the eye. Intradermal nevus can also be commonly mistaken to be the basal cell carcinomas. Now, trichoblastoma is another thing that can mimic basal cell carcinoma, and clinically it can be quite difficult and challenging to differentiate the two. So if you can't be sure whether it was basal cell carcinoma or not, then do refer for a dermatologist to assess. Now, how about pigmented basal cell carcinoma? So this is a type of basal cell carcinoma that we see more and more these days, particularly to the darker skin types. And so this is a dermatoscopy of a typical basal cell carcinoma without the pigments, and this is a dermatoscopy with a pigmented one. You can see this kind of ash leaf pigment granules in addition to the normal structures of the basal cell carcinoma. Now you may ask that how do I differentiate that with a melanoma? Dermatoscopy techniques is the most important one, okay? But if you have any doubts and if the history is not showed rapid progressions, do refer to as a 2-week wait, because we do not want to miss a melanoma. Okay, so and morphic basal cell carcinoma is when that basal cells, the basal cells grows with this kind of scar-like branches that it's difficult to see where it starts and where it ends. Okay, luckily this is one of the rarest type of basal cell carcinoma. But when this type of basal cell carcinoma occurs, then we almost certainly need to think about more advanced therapy, because this is typically quite invasive and difficult to treat with conventional surgery. So multiple biopsies and most micrographic surgery with or without radiotherapy are often needed to treat this aggressive type of BCC. Superficial BCC then. So instead of nodular BCC, which grows out like a bowl and with a defined margins, superficial BCC grows horizontally, and sometimes it can be difficult to tell where it starts and where it ends. But because it's stay at the superficial layer and closer to the external areas of the skin, and then it opens up different treatment modalities compared to with the nodular BCC. For example, we can use imiquimod, which is an immunotherapy that triggers the body's immune system to burn away the superficial BCC. Photodynamic therapies is we apply the cream to make the skin more sensitive to light and essentially burn off the superficial BCC, or the more physical way of literally scraping off the superficial BCC or freeze those areas off. Although I have put that in quotations and in brackets, because this type of treatments can be quite painful and not as effective as other types of treatment we listed here. It is not unusual to have some nodular components along with the superficial BCC, such we are seeing here. Largely, this is a superficial BCC, but with a nodular component there. In that case, excisions should be considered, at least for the nodular part, and treat the rest with other means that we talked about. Now, the difficulty sometimes is to distinguish superficial BCC from other type of skin presentation. As you can see here, at a glance, they may all look very similar, but clinically they are completely different, and it's important to differentiate the difference. So let me go through that with you. So you have seen this pictures in the previous slide. This is superficial BCC, but it can be very difficult to tell it apart from the IEC, which is the intermediate step before it becomes squamous cell carcinoma. Discoid eczema, so this is a special type of eczema that can be very, very itchy, and of course the treatment will be similar to eczema with, for example, this very potent topical steroids, and not the same as basal cell carcinoma. And this is tinea corporis, or ringworm, and get its name because this ring of peripheral scald or hyperkeratosis at the periphery. And the treatment, of course, is with antifungal treatment, such as like topical terbinafine or oral terbinafine also. And it can be difficult to differentiate or any of this, and it is important to take a detailed history and examinations and treat it properly. Now, we talked about the IEC, so let's talk about this squamous cell or squamous proliferative skin conditions. So we talked about like the UV light is the most important risk factor for skin cancers, and it can cause mutations of the cells. When there's only some changes to the DNA, and that it can cause actinic keratosis. When the mutations accumulates and the cells that acquired some of the abilities to multiply, but not yet able to invade, so it stays within the epidermis, and then we called it IEC, intraepidermal carcinoma, and which is the intermediate step before it acquires the ability to dislodge and invade, sometimes even metastasize, and that's when it becomes invasive SCC to the local structures or the surrounding nerves or lymphatic systems or the blood vessels, which give it the ability to travel further away. So this is a continuum of AK, IEC, and SCCs. Of course, the treatment aim is stop it early so it never has this progression, becomes SCC, which at times can be very difficult to treat. So I do recommend you to familiar yourself with the local treatment pathway for actinic keratosis, and you can type this to the Google and you'll find how we treat each type of AKs, but I'll give you an overview now. Okay. So let's talk about the single lesions or a few lesions of the actinic keratosis. If it's only a few areas, especially if they are hyperkeratotic, that means the scaly things on top, then freezing therapy can be a very effective way to treat, because that means that it's done and dusted in the clinic, and as long as you give the patients like clear instructions, and those areas will heal up in a few weeks' time. Topical treatments can also be possible to treatment options, and this is good if the patient that can't apply the treatment themselves at home and can follow your instructions. But it is very important to consult the patient properly, because it's expected side effects of the topical treatment. Right, okay, so for IEC, or the thicker areas of the actinic keratosis, often we will need treatment longer and more aggressive to make sure that we control it so that it never becomes a skin cancer. Cryotherapy can sometimes be used, but for large areas it can be too painful and doesn't reach the treatment effect that you expect, and therefore often we will want the patients to use topical treatments for slightly longer durations, and for example using imiquimod five times a week for 6 weeks rather than shorter durations that can be used in actinic keratosis. And the reason is we wanted to treat it and elicit the immune response with a longer treatment. And do assess it after your treatment period so that you can see whether there's still any residual disease such as here. Then you may need to use other treatment modality such as curettage surgery or photodynamic therapy. Okay, so we talked about a few areas of the AKs and even thicker areas of IEC. But how about when you have a large area of field change? That means that the whole area has had excessive UV exposure and has multiple actinic keratosis on it. Then when that is the case, cryotherapy is neither practical or helpful, and we do need to think about more area treatment. And for that, the Effidix cream or 5-fluorouracil is probably the most common type. It has clear advantage that you can treat a large area and generally very effective in terms of clearance. And cosmetic appearance can be quite good after the treatment. But the patient needs to be consulted regarding the side effects because it is expected to happen, and that's how it works. So I'm just going to show you the slides regarding to what to expect regarding Effidix or 5U cream. And so this is a patient slide who applied to the bottom half of the face. You can see that some redness is expected 7 days into the treatment, and much more redness and some crusting coming up for day 14, and at around 3 weeks time you can see much more to widespread inflammation. But the most important thing is 2 or 3 weeks afterwards the inflammation would improve, and we sometimes explain to the patients that this cream will burn off the sun damages and therefore to restore the skin to a better state. Okay, so cutaneous haunt is common presentations of actinic keratosis, sometimes with seborrheic keratosis as well. And it is not a dangerous condition by itself, but it is important to establish what is underneath the compact keratin that produce this keratin horn. And often we do see this kind of patients in this dermatology clinic, so that we can decide whether we need to do just the freezing therapy, curettage surgery, or more advanced therapy if we're suspecting more aggressive type of skin cancers. Now, all the other things we just talked about is to prevent the development of squamous cell carcinoma. But before I want to talk about squamous cell carcinoma, let me talk about keratoacanthoma first. So keratoacanthoma is a rapidly progressing and skin lesion, typically around like 6 to 8 weeks to reach the maximum size and then plateaued at the area. So this is a perfectly round or oval shape of lesions with acantholytic or the volcano-like the keratins in the center. It also typically has this shouldering or kind of like narrower base and then larger areas on top. So keratoacanthoma is actually an inflammatory or reactive process that if you leave it for a few months, it will regress itself and then completely disappear by itself. Well, I think that you can accept the difficulty to differentiate the keratoacanthoma with SCC looks like this on the slide, and it will be difficult for any clinicians to leave that alone without proper management or treatment. And therefore, for keratoacanthoma, we treat it the SCCs, and we want to remove it and check under the microscope, because even histology can be strikingly similar. Okay, so and SCCs, like I mentioned previously, is when the mutations meant that the tumor acquired the ability to invade and grow rapidly. and we wanted to treat it as early as possible. That's why there's a two-way referral pathway for SCCs and prevent it to develop into a larger and more difficult to treat areas like this. And sorry about the slides being cut in half, but we talked about oxidative stress or chronic ulcers is a risk of developing skin cancer, and this is a typical type called Marjolein ulcer. That is the skin cancer arising from chronic ulcers here. So I covered the basal cell carcinomas, squamous cell carcinomas. Let's talk about melanoma now. And this is the four types of melanomas here. Superficial spreading melanoma is the commonest type. Nodular melanoma grows very rapidly and can be very aggressive, and we do want to treat it as soon as possible. And this is in contrast with lentigo malignant melanoma, which typically starts off with pre-malignant lentigo maligna, and then progresses in the methods around 10 or 15 years before the invasion comes. But it can also be very aggressive once the mutations that kicks in, and it becomes very rapidly progressing. Acrolentiginous melanoma is a special type of melanoma that's for example, here it's in the toe, and sadly, this type of melanoma presents late. And for this particular patient, you can see the involvement of the whole of the nail unit with the clear involvement of the skin shown here. And this patient will likely require amputations of the toe to prevent progression of the disease. So you may have heard of or be familiar with this ABCDE mnemonics to help you to identify the melanoma. So A for asymmetry, that means that the growth of the tumor is not symmetrical, which is of course abnormal, and the borders is uneven or unclear, and color, if it has two or more colors inside lesions, or the diameter is larger than 7 millimeter, then those examination signs should prompt you to think about malignant melanoma. Evolution, of course, is not examinations, part of examinations. Instead, is part of the history. You want to check with the patient whether any changes of size or shape or color has happened recently. And one of the most effective ways to know that is actually ask the patients to monitor their skin with regular photographs so that we can tell the change. So that's A, B, C, D, E. But there's another important factor that we usually use as a clinician, and that's something starts with F, and F for something funny, or the ugly duckling signs, which means that if the patient have like many of these smaller lesions, but have one that is significantly different from the others, or significantly changed and becomes different, then that is the signs that we want to look at and consider whether that is a melanoma or not. I'll give you an example. For example, this young gentleman has multiple moles, but you can see and appreciate from the center part looks different from all the other moles, and it has indeed increased in size in the previous 2 or 3 months. And when we remove this and check this under the microscope, this has confirmed to be a stage 1A malignant melanoma that has been treated by complete excision with 0.7 millimeters of breast thickness. So what do I mean by this breast thickness? Which means that the invasion level of the of the malignant cells. And so when the malignant cells that acquires with the mutations or loss of the protections of the cell cycles, it means that it will grow and then invade. And the breast cell thickness is measuring of how deep it goes into the dermis. The deeper it goes, of course, it has a higher chances of metastasizes to the other areas. So this is another diagram to show you about the depth of the breast cell thickness, how it's measured, and typically that's if it's confined to a dermis and Clark level 2, then papillary dermis, so then is low grade melanoma, but if it's more than 0.9 or 1 millimeter, then that has a higher potential to become more troublesome. I won't bore you with the details in this slide, the very busy slide of the AJCC 8 versions of the melanoma, but you're very welcome to attend the skin MDTs where we'll discuss all the advanced melanomas and what the best treatment modality for them. But I have to say that in the last 10 years or so, the treatment for advanced melanoma has come around significantly, and the patient survival rate really improved in the last 10 years for these patients. Right. And let me cover thankfully a rarer type of melanoma, which is amelanocytic melanoma, as the name suggests, which is not pigmented melanoma. This is usually very aggressive and poorly differentiated melanoma, and it is important for us to pick up as soon as possible and treat it properly. Otherwise, the chances of metastasis are high for this type of aggressive cancer. Sometimes with the untrained eye, it can be difficult to differentiate that with pyogenic granuloma, which is an outpouch of the capillary blood vessels, or normal angiomas. So it is important to differentiate that, particularly from the history, and have a high index of suspicion to treat it and refer and treat a melanotic melanoma. Right, that concludes my talk on the common skin cancer types. I hope that this message will stay with you. That is the importance of UV protection. Ask the patient to self-monitor with photographs regularly, and treat any pre-malignant conditions as soon as possible and prevent it to become skin cancers. And if you have any doubts or not sure about anything of the skin lesions, do refer the early for the patient to have the best care possible. And I'm sorry that I can't be there to take your questions, but if you have any questions, do let Riyadh and the organizer know. They are more than happy to reply them. Thank you.